Okay, good morning, everybody. I'm sure there'll be other people joining along the way, but I think I'll kick off because, as usual, we have a really packed agenda this morning. So welcome to the National and Southeast Shared, I've forgotten what it's called, webinar, which we're focusing today on perinatal provider collaboratives. Can I have the next slide, please? So normal housekeeping, I'm sure that most of you on the call would have been, if not to this webinar, to many, many webinars over the last few years. So normal rules, please switch off your cameras and mute your line. We've put there to raise a hand to let us know if you want to ask a question, but today the agenda is so packed that we're asking for all questions to go in the chat, please. And we have a lot of experts on the call, and so your question will get answered. And if for any reason we can't answer it today, we will get back to you. So do put any questions in the chat. Okay. Oh, Ruth's saying she can't hear me. I think, can you hear anybody else, Ruth? Oh, she won't know, will she? She can't
I can
hear
check.
me.
Ruth, can you hear me? It might be worth if it's a sound thing, sometimes dialing in on your phone might be helpful rather than trying to go in on Teams so you can see the slides, but you can dial in for sound.
Okay, can I have the next slide, please? So, as I said, we've got a very packed agenda. What we're hoping to do today is to present you with the concept of perinatal provider collaboratives. We're hoping that there's something for everyone. So if you're on the call and don't know much about them, we're hoping that you'll leave knowing a lot more about them and why they're coming into existence. If you know a bit about them, then I think there'll be stuff on the call for you as well, because we're talking to people that are a little bit ahead in the process. And so I think it'll be a really good morning to sort of help understand more about where we are nationally and, you know, how each area can do its bit to move this along. Okay, next slide, please. We couldn't really hold a perinatal webinar at the moment without mentioning the really sad passing of Margaret Oates. Margaret was an absolutely visionary perinatal psychiatrist who was really instrumental right from the start at getting things going. An absolute legend, terrifying sometimes for those of us on the call that worked with her. So passionate. Making perinatal mental health have its own faculty at the Royal College of Psychiatry, and also with the setting up of the CCQI, which I think has helped immensely to keep really excellent quality throughout our perinatal community teams and our mother and baby units. So we absolutely wanted to not miss an opportunity just to say what an absolute loss. She's still working almost up to the end and still as passionate about perinatal all the way through. So safe travels, Margaret, and rest in peace. Okay, next slide, please. So just a little bit of a sort of starter for 10. We wanted just to remind ourselves about where we've come from in this process. So with the sort of passion of people like Margaret, perinatal has definitely come under the spotlight now and has started to receive all the funding that we were hoping for over the years. And so this slide just reminds us of those very early things where we were looking at the cost of untreated perinatal mental health illnesses and the LSE report, and all of those drivers for this programme, and suicide remaining the leading cause of death for women in the first year after giving birth, which I always think is such a chilling statistic. Next slide, please. And also, as this slide says, we've come a massively long way. If you look at the heat map from that 2015 one that the Maternal Mental Health Alliance produced, with all the red and pink and amber areas, and then it gradually turning green in early 2018. But the latest one, I think, will show even more changes. And we're very excited to see the latest iteration, which I think is going to be produced quite shortly. Next slide, please. And then just a reminder of our commitments under the long-term plan. So I won't dwell on the community commitments. I'm sure you're all familiar with them. And of course, there was the MBU expansion. And I think leading into our discussions about provider collaboratives, it's so important that we now start to pull things together and actually work collaboratively between those community services and those inpatient services, so that we can just make the whole process for women equitable and equal and seamless. So Mary's going to talk a little bit more about the why. So we'll go to the next slide and I'll hand over to Mary. Thank you.
Thank you, Jenny. And apologies, I am a bit coldy today, so you're going to get a bunged up me. So hi everyone, I'm Mary Pappin. I'm a programme manager in the National Provider Collaborative team, and I'm working with our national specialised team and colleagues to stand up perinatal provider collaboratives. So massive thanks to Jenny and Liz, so the South East Clinical Network, for letting us kind of commandeer their amazing monthly series to talk about perinatal provider collaboratives. So if we go to the next slide. Firstly, what are provider collaboratives? So for anyone on the call that has heard this pinging around, there's NHS-led provider collaboratives, there's ICB provider collaboratives. In terms of the specialist provider collaboratives, and that's what we're looking to work on for perinatal, these are groups of providers and partners who take on financial and clinical responsibility for specialised services. So a mental health trust. And I say NHS-led through this just because, as I say, we know ICS are setting up their own provider collaboratives, and they might be across mental health. But when we're talking about NHS-led, we're talking specifically about a specialised service. And for those NHS-led ones, we're essentially shifting commissioning from national and regional to more local commissioning, and then within that shift enabling the people that run and use the services, so our service leads, our clinicians, our experts by experience, to lead on that commissioning at scale. So the focus of those collaboratives is about ensuring people are treated as close to home as possible, where that's their choice and preference, and that the care is really well connected to local teams and support networks for the whole of the country. So currently we have 48 provider collaboratives now live across the country, and that covers 100% of the population. So that's for our adult secure services, adult eating disorders services, and children and young people's inpatient mental health services. So those provider collaboratives, NHS-led provider collaboratives, now manage around 74% of the national specialised commissioning mental health and learning disability and autism budget. And so they've been stood up over the last 3 years and what was known as phase 1 of the programme. And now we have phase 2 of the programme, which includes a number of service lines, notably perinatal. So that's what we're looking to do and have been working on. I know there'll be partners on here that have been working intensely over the last year and the year to come to stand them up for perinatal. So if we go to the next slide, thanks, Beth. Why provider collaboratives for perinatal? And I think this is a question that comes up a lot, even now when we're well into the implementation phase, as it should, because what is being proposed or already being implemented, as we'll hear from some of our speakers, is fairly radical. It's changing a commissioning framework that we've had for many years, that our MBUs were nationally commissioned and our community services are commissioned by our ICBs, which will remain on the community side. But how do we bring that together? And I think any change feels particularly sensitive for perinatal. I think because to Jenny's earlier points, it feels like we've only just got in the last few years the kind of focus and funding from government on perinatal mental health. And with more to do on kind of that mild to moderate end, and parent infant whole family approach. So I think we feel very protective, and any change feels concerning, I suppose. And I guess it's important to say that that funding and that focus is not going anywhere through this shift. What it's looking to do is to protect and enhance all the great work that has already happened in the last few years by handing responsibility for the commissioning of our specialist services to those people that have been on the ground, that have done all the work along the way, to say you are best placed with your experts by experience to decide what is commissioned for your population of women that can benefit from this specialist perinatal mental health care. And on here on this slide, we've got one of the clinicians described this really well and said, there is a need to shift from thinking about individual services and the boundaries and contracts for that specific service to thinking much more ambitiously and thinking about transformation at scale that can meet the needs of whole populations. So we did kind of a 2-year engagement over the ambition for perinatal and a huge amount of engagement with women with lived experience through our expert reference group. And the overwhelming point that kept coming out of that group was that women wanted better joined up care between specialist community perinatal mental health services and MBU services. And we know that that already exists, right? In a number of areas, that joined up care is already working incredibly well. In spite of, different commissioning arrangements, it's working. And so I guess one of the challenges is with why do perinatal provider collaboratives? If it's not broke, don't fix it. But I think the point is we know it's happening in some areas, but is it happening in all areas for all women? Do experiences of care look the same for women with an MBU on their doorstep as those women who may have to travel? So I think PCs are trying to be much more ambitious and say what is already working well, let's make it work well for everyone. So the national engagement I mentioned, that was with commissioners, providers, clinicians, obviously experts by experience, who agreed the way to do that in terms of how do we make this work for everyone is to work collaboratively as one under one collaborative. And I think when you have trust bidding against each other for ICB funding, for whatever scheme, or competing over populations in terms of, access targets, that's very difficult to do. The ambition for PCs is to enable shared governance arrangements so providers can take decisions together that will speed up service improvements and transformation for a whole population across a whole pathway. So that's why PCs. If we go to the next slide. What does success look like? And we've got a really lovely quote here from one of our experts by experience, but I know Amy, who's going to join us for the last section of the day, will probably talk much better to that than I would. But success, it is about clinical and expert by experience leadership at that commissioning level. It is about whole pathway working at scale. So working with our brilliant perinatal mental health clinical networks, working with ICBs, and not just working with, but formally partnering with these organisations and our trusts that are delivering the community teams and the MBUs, partnering formally so that we can work as one. And I think, that seems natural. We are all responsible for this population of women, but the breadth of people that need to be involved in this is absolutely huge. So I think working as one is a really easy thing to say in terms of what does success look like. I think in practice, it is massive what we're taking on for perinatal provider collaboratives. It's a shift that requires a huge amount of trust and a lot of time, and we know that capacity is tighter than ever. But we are already starting to see so many benefits from our phase 1 providers in response to this model, in response to workforce challenges, out of area placements, lengths of stay, more equitable access and egress across inpatient and community. And I think that's really exciting to think we can have that for our population of women that we know can benefit from our specialist perinatal mental health services. But as I say, that is what success looks like, but we'll have Amy at the end of the day who talks beautifully to this in terms of collaboration. So that is all from me. If we move on to our next slide, I'm going to hand over to our lovely Southwest colleagues.
Thank you, Mary. I'm just going to double check as there have been issues. You can hear me okay?
I can hear you fine.
Thank you. There's only one Claire today doing this. My colleague, Claire Doble, is not able to be here today. So just to explain that. So I'm Claire McAdam. I know quite a lot of you from my Devon perinatal general manager days, and I've never lost touch with perinatal. I now work with the Southwest Provider Collaborative as a clinical director on the commissioning of mother and baby units. So I'm just going to share the slides. In the beginning. Sharing. Can you see that now?
Yeah, I can see that, Claire.
All right. Okay, so I'm able to move it to my other screen. Apologies. Always easier when it's in front of you, isn't it? I'll look to the side. So the Southwest Provider Collaborative covers the geography I've got on the screen here, where there are 3 mother and baby units, one in Exeter and Devon, one in Bristol, and one in Bournemouth. So quite a big geography. I think from previous days, what we've learnt with a bigger sort of more rural area, particularly Kent colleagues, I remember having conversations with, that is very challenging. But that's the Peninsula, the Southwest Provider Collaborative cover already with other services. So they have forensic, inpatient and community, CAMS, inpatient and community, and eating disorders inpatient. The provider collaborative have been going since 2017, so have a fair bit of experience. And I have to say, coming here today, we, are not in contract with NHS England. We're, like others, still awaiting to hear the next steps. But this is a reflection from us on that phase 1, as Mary mentioned earlier. So the themes, I'm minded actually as you spoke, Mary, a lot of the themes will be quite consistent today. So apologies for a bit of repetition, but at the same time, hopefully that fleshes out the story and the narrative around the benefits of working in provider collaboratives. So the ambitions are, should we be successful, to look at equity across all of the 3 mother and baby units in the Southwest, of course seeking that high quality care and treatment for mums to be cared for closer to home. Again, with the geography, that can be quite difficult. But one area in the Southwest, the Exeter unit, have an outreach service. So there is learning potentially that could be shared across the peninsula. Always looking for that evidence-based development. So where there are new approaches, that learning, how can we embed that across the peninsula? Looking at pathways. So again, this was mentioned earlier, we would be looking at a care pathway approach that was the whole care pathway. So going from community perinatal to outreach where there is that service, into the mother and baby unit and out again, and looking at, is there refinement, is there improvement, how can we look to benefit mums and babies? And of course, linking in with our other colleagues along the pathway, not forgetting health visiting, midwifery, primary care, and of course the voluntary sector as well. Reducing lengths of stay, you know, of course, that's always an advantage where that can be achieved, but it has to be managed safely and with good community support. Where we're able to do that potentially, and we've seen this with the other provider collaborative systems, where there have been efficiencies made, that's been able to be reinvested into local services. So holding on to that ethos of a local organised service, local commissioning, local benefits. That reducing delayed discharges, I've already mentioned about that wider system approach. So in the Southwest, there is a perinatal and infant mental health clinical network. So rather than developing more new networks, looking to align and work alongside colleagues who are already there. So that little summary about, again, should we be successful, ensuring high quality treatment, that treatment is timely and effective, and improving patient experience. And that's not to say that it's not good now. I think that's really important. It's sometimes those smaller gains, isn't it, that can be made. So phase 1. So this is from the Southwest Provider Collaborative. I have got a Southwest NHS England summary to share with you as well. So ensuring we did our needs assessment, we did some work with NHS benchmarking, really an ability to drill down into the data, looking at admissions, staffing, the geography of where women were coming from, etc. The skill mix of staff in the mother and baby units, really interesting detail. I've been appointed, I haven't been in post that long, so I'm a day a week with the Provider Collaborative while we're in this sort of phase 1 still. We would be still talking about that single point of access, and I'm minded of web beds that I know Jenny Walsh was the innovator of. And NHS England have been very clear that looking at the bed stock across England, that wouldn't change. So of course we would be looking to embrace that, and important we use that capacity again wisely and efficiently. The organisation, the Provider Collaborative, have been doing due diligence, looking at the clinical case for change. Again, looking where there may be improvements and how can we draw learning from where we've already done some of this work. That really important collaboration, initially it was with the Devon clinical commissioning groups and other CCGs, now ICBs and ICSs, making sure that we are well connected and in dialogue on a regular basis, so that as a system we are all working together, aligned and on the same page. So what would our next steps be? Of course, we have to await that award announcement. We would share the needs assessment work that we have been doing with our peers and our colleagues. Really, the richness of those perinatal colleagues out there will be invaluable, those people on the ground who are already doing the work. Looking to co-produce the clinical case for change involving other professionals, women with lived experience, their partners. You know, how could we do this differently? Having those experts by experience, absolutely the golden thread through all that we do, and looking at a mobilisation plan for the next 3 to 5 years, depending on what comes next. So my NHS England colleagues, these were their reflections. So there are similarities, there are some differences. Their 3 key points were relationships and communication. They mentioned about the work undertaken previously with CCGs, provider collaboratives, etc. It was a bit of a challenge, I think, putting people onto that same page approach. had its challenges, but with that sort of resilience and kind of holding the case for change and improvement. In that first phase, work has progressed. Still a lot to do, and there is a strong relationship already with the Southwest Provider Collaborative and our NHS England colleagues, which is a real strength, I think. Looking at the pathways for women, already some innovative work to build on. Again, important that we align our programme of work with the greater work of the ICBs and ICSs, our aspirations. So for women in the perinatal period, thinking again about that care pathway. So the commissioning, as most of you will probably know, for community perinatal services still will sit with ICBs, ICSs, and we want to avoid any unintended consequences around those differing commissioning responsibilities. Ensuring we have good governance and assurance, that's strong within the provider collaborative. Again, our relationships with NHS England, we have to assure equally that our systems are in place. So keenness that we don't duplicate work, we are on the page, etc. So just to summarise, that focus on quality and safety, patient experience and outcomes. There's been a lot of work I know already conducted around PREMS, PROMs and CROMs in perinatal mental health. So absolutely championing. How do we know we're, our achievements are on the page, we're doing the right thing, and enhanced understanding. So from that NHS benchmarking data, but also going out and meeting with teams in mother and baby units, excuse me, croaky, looking at that clinical variation, because there is variation across the 3 units in the Southwest, the number of beds, the staffing complement, length of stay, etc. So it isn't very much about coming in and saying that things need to change. It will be developing that intelligence and greater understanding of what is already out there. How can we enhance and improve together? Equity of access, I've already mentioned, and ongoing experts by experience involved in all that we do. Again, should we be successful, we would be looking to develop and go into that next phase, working more closely with people with lived experience. So I'm going to stop sharing. Sorry, that's a bit of a whistle stop. And Jenny and Mary, I am happy to take any questions if that's helpful now, or if you want to just leave it to the chat.
Hi, Claire, lovely to see you. I think because of the pressure on the agenda and the timekeeping, it would be great if you don't mind answering in the chat. And I can see that we've got one in there already. And Jen Cook, you've got your hand up. Do you mind putting your question in the chat, Jen? And Claire's around to answer it. So is that okay? And then I think
Absolutely fine.
We'll crack on with our next speaker. So is that all right with you, Mary, if we do that, and hopefully for once in my webinar career we might stick to time, although I'm not the best timekeeper. So lovely to see you, and thank you so much for that, and I'll leave you to answer the questions that pop up. Okay, can we go back to our slides? Beth, please. Lovely. And if we just get back to where we are on the agenda.
I think there's lots of delays today. A couple of people have kindly highlighted that Microsoft is having a meltdown across the world, apparently. So that was
Oh,
nicely timed, the webinar.
brilliantly timed. Okay. And do we have Andrew on the call? Because I know Andrew was very kindly jumping in straight from his MDT this morning.
He was going to try for 10:30, but if I said, and I hadn't checked this with you, Claire Hayward, but if Andrew hadn't quite managed to get on for 10:30, we can always switch up if that works.
I'm quite happy to go now if you want me to. It's fine.
Maybe we do that because, yeah, Andrew was ducking out, bless him, to come and give us half an hour.
No worries. No worries.
Yeah.
That's brilliant. And we have another lovely Claire. So I don't know what you call what the collective noun is for Claires, but it's definitely a webinar of Claires, isn't it? And thank you so much, Claire Hayward, who's, as you can see, Senior Programme Manager for Kenton Medway and lead for perinatal mental health and maternity. And so I'll hand over to you, Claire. You're going to talk to us about your experience so far with provider collaboratives. Thank you.
Thank you, Jenny. That's great. Thank you. And yes, I'm Claire Hayward. I'm the lead perinatal mental health commissioner, and I've also got another hat which really helps me actually with my perinatal mental health commissioning role, which is that I'm also the maternity commissioner for Kenton Medway. Next slide, please. I'm not going to dwell too long on this slide because actually Jenny's already covered this at the top of this agenda, but I did think it would be a good idea to initially just have a little look at recapping the journey that we've been on for commissioning perinatal mental health services. So as you all know, 2016-17, we have a Community Services Development Fund, and different areas of the country went out in different waves, not everyone at once, in terms of improving and expanding their perinatal mental health services. And we have been through a huge transformation. And certainly I can say in Kent, we started off with, I think, 2 nurses and a couple of psychiatrists. And now we have a huge multidisciplinary team, which include nursery nurses, psychologists, peer supporters. It's a fantastic multidisciplinary team. And the investment in perinatal mental health through the NHS long-term plan and that community development fund has really allowed us to do that. And then obviously with the long-term plan, the introduction of an entirely new service, the maternal mental health service. So again, huge work in commissioning and partnership with our providers in getting that funded and co-produced and implemented. And there's exciting rollout work happening, I know, countrywide at the moment. So I think the little bit of this slide, I think that's important to reflect on is that actually all of that work that we've done has given us huge gains and learning during this time. So we've got increased knowledge and experience of what works well, which will support the transition into provider collaboratives. And I think the primary thing, and certainly the primary thing for us, has been that we've really worked hard in establishing our relationships with experts by experience, establishing peer support in our services, and also understanding our communities so we can be really clear what people need, what women and families want, which is actually needs to be the centre of this work, and we need to keep pulling ourselves back to that. Overall as well, and the speakers before me have also reflected on this, that actually data, assessment, outcome measures, quality metrics, we've made, again, huge progress in understanding how to measure impact and how to measure what we want to measure. But of course, it's not only about data improvement, is it? And I think there's been the chance, again, working with our experts by experience, to really listen to and collect stories and narrative. And that offers the real qualitative measurements of our work as well. And I think it's really important to stand those up side by side, that the data does come with those narrative and stories, and they should always be presented together. And then in terms of commissioner learning, so for commissioners, I think there's been a real opportunity to learn about perinatal mental health, what that means, to partner with our services, and such an exciting opportunity to improve and develop services, but also build services with co-production from scratch. Next slide, please. I've noticed there's an error on this slide. You'll see on the left-hand box it says Integrated Care Partnership, and then it says ICS. It's actually meant to say Integrated Care System. Apologies for that. I think this is unlikely to be learning for anyone here, but I really thought I would just set out those changes since CCG ceased to exist and the elements of those new NHS structures. So on the left, you'll see the Integrated Care System. So you'll see that that's a formalisation of a partnership, and that's not just NHS commissioners and providers across that large geographical area, but also includes local authorities and other local partners as well into those kind of very formalised partnerships, and that they will collectively plan for health and care services, but over a wide system-wide population. So it's a local population approach, but with a very much a system lens. And those equal partnerships will be promoted through that ICS, and that will be reflected in governance, and we can see that governance starting to kind of roll through as ICSs are really getting into their rhythm. So chairs and lead roles will come right the way across those partnerships. It's not just the NHS taking the lead with those. And then on the right, you'll see the Integrated Care Board. So that's the old NHS planning function that was previously held by CCGs. Boards are setting out their integrated care strategies at the moment. I know in Kent Medway, we're working hard on ours, and it's really setting out what we're going to be doing over the next 5 years. And NHS, oh, I think someone's not on mute. Sorry, you okay to put yourself on mute? NHS services need to be delivered to meet local needs, and it will also set out the wider health needs of how our population needs can be met. Next slide, please. This is quite a busy slide, but how does the development of provider collaboratives with those newly formed partnerships and that wider focus of system working, how will that work together, thinking about perinatal mental health? And I think even though we've just had a couple of presentations so far, this just offers reinforcement to what's already been said, really. I think initially we can take learning from other provider collaboratives in other areas, such as learning disability and autism. But I think we need to have a recognition that perinatal mental health is very unique and is very special to all of us. And I think we want to do a good job here, and we want to make sure that the work we've done over previous years is preserved, and that we can really stand side by side with our experts by experience in leading this together. But the provider collaboratives are a good fit with these new NHS partnerships. So, for example, the focus on population health, the experience and outcomes of people using those services, it fits that remit of having that system-wide working and that kind of wider commissioning for outcomes approach. There'll be a strong focus on community and prevention support and empowerment for people to take charge of their own care, and that's certainly something that provider collaboratives with perinatal mental health can really support. We know that one of the things that is essential really is that lead provider model, which we're moving forward with perinatal mental health. It needs to be a provider who's already leading an MBU or a specialist team, so they'll already have current knowledge of what that looks like and what that pathway looks like, but also that provider should be a member of the local partnership with the ICS. So in terms of aligning commissioning strategy and approach, they'll be used to working with those other partners, but also being part of that partnership. There's an opportunity to strengthen that approach because the lead provider will be part of that partnership. So other providers, other commissioners, third sector, social care, local authorities. It's a real chance to kind of bring together and galvanise that opportunity. Improved collaboration, and transparency across the system. Obviously, that will be as a result of that. Working across historical boundaries, and someone's already mentioned those kind of boundaries that were previously put in with different structures. There's again a real opportunity for learning and improved care here as those boundaries start to kind of get set aside, and we move away from that boundaried working to looking at that total resource and planning at a wider level right the way across our population. And also there's opportunity here, I think, for perinatal mental health to have dedicated governance. So I know that with some perinatal mental health services sit within rather huge mental health providers or rather huge traditional contracting. And sometimes it can be really hard to have that dedication to perinatal mental health and to really focus on that service. So although governance is at an early stage in the ICS and partnerships, I think there's no doubt that there's an opportunity to have that dedicated governance around perinatal mental health, which will really highlight it and allow small services to shine. Next slide, please. I think I think the new partnerships are going to be driven by improving the care pathway for women, people and their families. And that's something, again, very familiar to us in perinatal mental health. We've been striving for those better outcomes for women and families for a very long time. And you can see there that, you know, there's a commitment, isn't there, with these new partnerships, that those pathways and services will be co-produced and developed. I think there's a chance here that I think we're very good in perinatal mental health, and I think we can always improve, but I think we're very good at working with our experts by experience. And there's a chance here, I think, for us to really influence that at ICS level, at whole system level, and really be a leader in showing how we can work with co-production, how we can work with experts by experience to stand our services up, and you know, how important that co-production is to the success of our services. There's lots of stuff that I think still to be worked out, things like transfer of budgets. I don't think anyone really understands how that will look, but the possibility of pooling budgets across services and the opportunity with that financial and clinical responsibility and seeing how that will look across a whole population. People have mentioned equality of access already, hugely important, and managing across that larger space does offer that opportunity. And then again, you know, linking our work in perinatal mental health wider across the system. So real opportunity to stand on that scaffold and see where else we can, I guess, you know, link in to ensure that perinatal mental health is really robustly placed within the system. Those new partnerships will give us a platform and a governance for that. I think, though, you know, the bottom line here is, you know, I think listening to experts by experience, we are one NHS. Women and families want better joined up care, and it's our responsibility to be led by that and to be led by what service users and experts by experience feel is best fit for the needs. And I do think the ICB structures, the ICS structures, will really allow us that, you know, that scaffolding to move forward with the provider collaborative work, which is what we know that women, families and people say that they really do want. Next slide, please. And it's the final slide, really, and it's just, I put this together, it's very crude, it's very high level. But it's just to say that, you know, we're looking at joining the pathway. So initially, you know, specialist services such as mother and baby units, but now looking at community perinatal mental health teams, maternal mental health services. But it's really important for us to also have an understanding of what's going out there at that almost that universal level, so that mild to moderate level, because we do know clinically, don't we, that women with perinatal mental health challenges can move up and down that pathway quite quickly, and things can become challenging quite quickly. Equally, we don't want people and women staying in beds that they don't need to be. They need to be back out into the community as soon as possible. So moving up and down that pathway as seamlessly as possible is really important. And I've put that universal offer down there because family hubs are going to be taking on that mild to moderate work, and it's going to be really important for us to understand that wider national context around perinatal mental health and what else is happening in our system that we can link in with to reinforce not only what we're going to be focusing on as provider collaboratives, but as provider collaboratives reach out and reinforce that whole pathway for women, people and families. So I just put that in there because I think that's really essential work, and certainly something in Kent Medway we're really looking to linking in our specialist teams with that family hubs work to ensure that we've got smooth referral pathways, that there's a really good understanding of trauma-informed care. And I think it's really exciting work that universal-wise, up until now, that mild to moderate work hasn't been included in long-term planning for the NHS, but is starting to come through with our partners in local authorities. So that was a really quick whiz through. I'm really happy to take any questions in the chat, Jenny.
That's brilliant. Thank you so much. And I hope for people on the call that those of you that have come to the webinar not knowing too much about provider collaboratives, that you're just starting to get a picture now and seeing what the gains are. So thank you so much for that, Claire. Oh yeah, so here we are on the next slide, and Andrew, thank you so much for whizzing across from MDT to do this. And Andrew's going to bring that other really vital perspective in now, which is looking at how we can enhance the clinical pathways. And I know you wanted to share your own slides, didn't you, Andrew?
No,
so,
I think Mary and Beth have got them.
Oh, so you're happy for us to be sharing?
Yeah, it's easier actually because you can see who you're looking at, which is always helpful.
Okay, brilliant. Well, I'll switch off my camera then and hand over to you. Thank you so much, Andrew.
Hi, everybody. For those who don't know me, Andrew Cairns. So I'm a consultant psychiatrist by day in the perinatal service up far end of the country from yourselves, up in the northeast, Northumberland, Tyne and Wear. We run a community team and a mother and baby unit in Morpeth. I think, and apologies for just crashing in, as Jenny said, it's our MDT, so I've come in the little gap, our tea break between patients, to talk about this, but I've missed the beginning. I think Jenny was probably giving us a bit of a setup at the start about where services have come from, thinking particularly about the recent sad loss of Margaret Oates. There is a hint of that. I'll try and go a bit quicker through that in my presentation. Can I just quickly check with those in charge how many minutes I'm aiming for? Is it about 15? Or...
No, you've got a bit longer, Andrew. You've got 20.
Right.
Yeah.
Okay. Oh, great. Well, I think it took about that last time, didn't it? So where are we in the northeast? So just to give you a bit of a sense of our setup, I think in some areas we're fortunate. Forgive me if our fire alarm goes off for its weekly practice in the background. I think in some ways we're fortunate in the northeast that we have a much more sort of delineated geography in comparison to some other areas of the country, particularly those where there's multiple ICBs covering one patch with a mother and baby unit. So we just have the one ICB and an existing provider collaborative partnership, which covers all of the previously delegated provider collaboratives, so that's forensic, eating disorders and SIPS inpatient across the same footprint. So we've got a lovely setup really in terms of governance structures. There's two mental health trusts, the NTW and TUBE, which work very closely together and have done for a number of years. Within that patch, we've got our one MBU and 4 perinatal community teams split equally between the two trusts. And in terms of our sort of neighbouring geographies, our southern border, which is the right-hand half of that diagram, the pinky bit and the light blue, as it were, which is County Durham, is roughly equidistant between Morpeth and the Leeds mother and baby unit. So although we do get some patients flowing across, they tend mainly to come from North Yorkshire up to us when there's a lack of beds in Leeds area. Over in the west, in North Cumbria, we have a bit more of overlap with the new Chorley mother and baby unit. They were commissioned to provide an outreach service which operates into North Cumbria and covers the patch of one of our community teams. But I think the real positive that we have up in the north is that we've got really great relationships between all of the 4 mother and baby units, Manchester, Leeds, Morpeth and Chorley. And we've already begun discussions with the Lancashire, which is the Chorley units provider collaborative, about how we're going to work with them to provide and maintain really the positive care experience that women get in North Cumbria. Next slide, please. As I say, I understand Jenny may have given you a bit of a background to perinatal services, and I think that's relevant here because one of the points I would like to make is, to some extent, this proposal of bringing back perinatal community services and MBUs together is a bit of sort of going back to the future, really. This is something that in most places was the standard before we had the expansion of community services across the country in 2016-18. Certainly from my own training experience down in Nottingham, the community team was born out of the mother and baby unit, and that was really very typical. There were very few exceptions to that, other than some outlying places like Coventry, for example, had a separate service. And it's a similar sort of story, although not quite the same in the Northeast. The community team, they had separate hospital trusts, so they were separate a little bit, but brought together and physically integrated. The community team sat within the MBU in the early 2000s, and then that's been broken up again as we've moved into specialised commissioning, and the MBU is directly commissioned, and obviously the teams, community teams and developed teams went under CCGs. And to try and address that, one of the things that we set up regionally was a training forum purportedly about meeting quality network standards and helping the teams get speakers for some of the more difficult to cover areas. But my main thinking when we set that up was about just giving an opportunity to bring together all of the professionals from the teams, to build those professional relationships and to really try and strengthen the links between community services and the MBU for the benefit of our patients. Next slide. I think some of this should be pretty familiar to anybody working in this field, and probably, to be fair, working in mental health more generally. The challenges that we had in providing our services prior to thinking about provider collaboratives were significantly around staffing. We had the setting up of several new teams, we had the expansion of other teams, and that required a huge amount of recruitment, and then challenges about not only training those staff, but retaining those staff. And the pressures, particularly around meeting access targets, long-term plan aspirations, have certainly had a significant impact on our ability to retain staff who at times have felt quite overwhelmed by the amount of work that they're expected to be undertaking. There have been challenges about fitting training within that and developing the expertise of the services and working towards how can we meet some of these aspirations, particularly the more challenging targets around working up to 24 months, about increased psychological interventions, and you know, particularly around preparedness for engaging in more formal interventions and being able to get women to that stage. We've found that the focus nationally, and I hope Mary doesn't get upset with me commenting on this, on the access target has been a real difficulty for us, particularly around some of the feedback we get from commissioners when they're not happy that we're not necessarily hitting that access target, despite, I have to say, not being resourced to do so. And then working across a patch that originally, prior to the ICB, had 8 CCGs, and of course had very differing views about the whole perinatal project, from extremes of commissioners in one area who felt that they didn't really believe in the model at all and made that clear to us, to the other extreme of commissioners who were extremely supportive of the transformation process and worked very hard with their colleagues to get other CCGs to support the development of the team. So a real sort of inequity, and that then leading to inequity in terms of what resource was provided to the teams and what service could be provided as well. Next slide. So the approach that we took together, I've touched a little bit on this already. I mean, I think the training forum was part of that, about bringing people together, building relationships. That helped, and also with the expansion program, bringing managers together, sharing information, sharing draft business cases to help each other, policies, procedures, some thoughts about recruitment and so forth. We've worked really closely with the clinical network, and we've been very fortunate, and I know you are too in the Southeast, that we've had clinical leads who have been members of our clinical services and very well versed in the challenges and help move that forward and supported, for example, the training forum. So they found rooms for us, financed that, tea and coffee, etc. And we've taken the approach really of engaging commissioners both individually and together. So in the Northeast, when the CCGs were running things, they always met together in large groups. There was a North and a South work plan meeting, as they called it. So there was that opportunity to discuss provision of services at that level, but also the need still to be looking at what we would now see as a place-based level about the particular needs at that level. But I think the challenge in all of this, as I've sort of alluded to, is that much of this really was informal. It was based on goodwill. It was based on personal relationships that we were able to establish. And whilst that is always necessary in moving things forward, it didn't really give us the formal structures that allowed us really to get a grip of some of the challenges, particularly with the community service end of things. Next slide, please. You've possibly seen this timeline before. I think it really just reinforces that this is not a new suggestion, that the development of the model for perinatal provider collaboratives has been ongoing for quite a few years now, and certainly came into the CRG, the Clinical Reference Group, back in 2019, and then led through obviously into task and finish and implementation groups. Within our own area, one of the things that I began doing was flagging up with CCG commissioners back in 2021 that this was something that was coming along. I think with the benefit of hindsight, possibly something I should have been more active in doing was trying to get CCGs to take the principles of a perinatal provider collaborative through their due governance structures, just to at least get the idea of it signed off as something that they were willing to work towards and have further agreements on. We've had significant challenge recently with our developing ICB, who feel that they really need to go through all of the governance processes again, understandably, because they hadn't gone through exec board levels with the CCGs previously. But that's then had a sort of delaying impact on us being able to move forward with the business case. Next slide. So what we're looking at, and I appreciate that different areas of the country may treat this differently, is a provider collaborative that's going to be incorporating our mother and baby unit and our perinatal community teams. In this little diagram, we've also got the two triangles on the right and left. So we've got maternal mental health service on the right, and parent-infant psychotherapy where it exists. It doesn't cover all of our region on the left there. We have not used a model of integrating maternal mental health services into our perinatal community teams, and if people are interested, I can explain why we've gone down that road. I know other areas of the country have done that's part of the team. And so essentially, we've seen that as being a separate function, which we're not looking for commissioners to delegate into our provider collaborative, certainly at this stage. So it's purely the sort of classic, as it were, perinatal team that's going to be part of our PC if we are successful. Next slide. So where are we at? As you would expect, we've had huge support, both nationally and regionally, from NHSE colleagues who've been very flexible around timescales. We originally were hoping that with a relatively straightforward geography, we might be able to get this all through in time for an April go live date. I think what's become increasingly apparent is that the situation with the ICB means that we're going to need to push back on that and probably align more to the national suggestion of an October go live date. The hindrance has been around this transition from CCGs to ICBs, about the fact that we hadn't managed to get the principles of the process through CCG governance prior to the ICB, and really, as is probably true in most parts of the country, that maturation of the ICB structures and a figuring out really of where decision making lies between place-based colleagues who still feel quite nervous about delegating responsibility to a provider collaborative, and the ICB that may be a little bit more open to it, but are still trying to sort of figure out how this would all work with all of the other responsibilities that they're taking on. Thank you. No, next slide is fine. So if we then think about where are we at in terms of the key principles that are in the implementation document. So in terms of working in partnership, hopefully I've given you the sense that for some time now we've been working quite closely across our two provider trusts, across our teams, bringing them together in more informal structures, using really significantly the clinical network to support all of that. And with the beginnings to develop our business case for a provider collaborative, we've then begun discussions more widely with the provider collaborative team, particularly in Lancashire, because of that significant overlap in North Cumbria, but also discussions with Yorkshire and Humber about where they're at with their work, and had some emails recently from them just this week asking for draft business cases to consider themselves. Thinking about how we work across the pathway of care, and I think that's really the huge opportunity, is to really improve that flow of patients from the community into hospital and back out into the community. It's not that infrequent where we find ourselves, so with my MBU hat on, reviewing referrals for admission, when we perhaps reflect back on some of the information and think that perhaps if things have been done slightly differently in terms of community care at an earlier stage, that might have led to a different situation and potentially not necessarily requiring admission at that stage. And what we would really love to see and build on is a much greater sharing of expertise across the whole pathway, the community and the inpatient, a much greater awareness of the patients who are out there. So for the inpatient team, having more awareness of patients who are admission vulnerable. And we do have a bit of that in place. We have an admission vulnerable board, which community teams are encouraged to give us information for, so we can flag up patients who might be at risk of admission and therefore smooth the process of admission when they get referred in. But really trying to improve that support across both ways, and likewise, from community into the ward, think about how those links work so that there's good relationships for the women on discharge back into their community teams as well. And COVID has had a bit of a positive impact. I think, the use of Teams routinely now for MDTs has really improved attendance of all professionals, including other services like health visiting, for example. We've got some lovely examples in the northeast of some really good third sector involvement. In North Cumbria, there's a fantastic charity called Happy Mums, who provided a huge amount of support before the community team there was even set up, and continue to work with our perinatal community team in North Cumbria, and would like to build on that and develop similar arrangements in other areas. And really trying to continue to strengthen the links with other areas of the system. We've now got in place, I think, pretty much in all of our maternity systems, specialist midwives now, which certainly was something that wasn't present even just a year or two ago. And as things begin to normalise coming out of the COVID pandemic, there's some real opportunities to strengthen our links with them also. Thinking back to my experience of the East Midlands, when there was a strategic network for perinatal mental health there. In those days, there used to be regular bringing together of all of the specialist midwives with the community, with the specialist services, both improving those relationships and looking for training opportunities across the whole. So that would be something that would be great to see in the northeast. Next slide. So the key to all of this has to be ultimately about transforming care and about improving the care that we provide and the quality of care. Now, our provider collaborative partnership recently did a really great piece of work with Rethink, looking at how they're directly involving lived experience in the partnership, and really developing much more formal and also to some extent paid structures to support individuals with lived experience to really influence the decision making that we're taking. So that's something that we'd like to integrate into our Developing Perinatal Provider Collaborative. We've had some recent reviews of our community teams done by North East Commissioning Support, NEX. They really drilled down into the data of the patients that we're looking at and found some very interesting information, particularly around levels of social deprivation. So almost 50% of all of the women that come through our community teams sit in the bottom 2 deciles of social deprivation. And also some interesting findings, and I wonder what clinicians' views in the Southeast are of this, really around rates of DNA. And we've seen our DNA rates for assessments absolutely skyrocket coming out of COVID. But what the data shows is that we are seeing these women eventually, but that has a cost in terms of the number of missed appointments prior to the assessment taking place. With another hat on, I am involved with, and one of the things that we're looking to do is really take out a lot of the learning around the social complexity that many of the women who are sadly dying have within the maternal deaths inquiry. And I've had some recent discussions with our maternity clinical lead in the networks about how we might take that work forward and think about improving the care as a whole our system is providing. And we know the North East has got some of the highest levels of social deprivation and inequality in England. And then the final and highly contentious issue about delivering the long-term plan commitments, which none of our community teams currently are in a position to do. And really what we're hoping to do is work very closely with the ICBs about thinking about where we're at, what financial resource they're able to commit towards further development, and then probably almost more importantly, what staff we're capable of recruiting. We've recently had a situation where we've advertised for Band 6 clinicians and we've had no applicants. So we're really reaching a very difficult point in terms of staff recruitment, and that's common across the whole of our mental health services. Final slide. I think much of this I've really covered on. Clearly in terms of the Developing Provider Collaborative, we are clinically led, so I'm going to be the clinical director for that service. We have already began involving senior leads from all of our community services and the MBU in the discussions about the business case, and we'll be looking to set up work streams around the care that we're providing to think about how that's developing, which is going to involve very directly that clinical leadership as well as lived experience. I think we need to maintain the flexibility that we really benefited from in terms of the setup of specialised commissioning and direct commissioning of all the mother and baby units, so that we're not putting in place arbitrary barriers to care being delivered where it's in the best interest of the mother to be delivered. That's most obvious for us in North Cumbria, where the sort of complexities of the geography and a few mountains getting in the way makes travel quite challenging at times. And so for some women, it's much easier for them to access the Chorley mother and baby unit, perhaps, than travelling across to the unit in Morpeth. And we want to maintain that opportunity for women to get care that's most accessible to them, despite it perhaps lying within a different provider collaborative area. And of course, ensuring ultimately that the care that we're providing is both high quality, as near as to home as is appropriate, and in a timely manner. I think that is my last slide. Yes, so happy to take any questions or reflections indeed on any of that.
That's brilliant, Andrew. I don't know if you heard at the beginning, but because we've got such a packed agenda, we've asked for questions to go into the chat. So if you're okay to pick them up via the chat, and I can see there's already one in there from Jen Cook from Sussex. So that would be, and one from Claire as well. So can I leave you to answer those? And
I'll sit and scribble some responses.
Jenny, is it worth, sorry to interrupt, because I've just been waiting to hear, so Amy, who is Amy has many hats, but also was one of our lived experience reps involved in the original ambition. She's coming from another meeting. I was going to say we could do 1 or 2 questions if you were delayed, but she's just popped up. Ignore me.
Okay, brilliant. So Amy, I'm delighted to introduce you. You're going to talk about this from the lived experience point of view. So over to you, Amy. Marvellous timing.
Yeah, I've just literally hopped over from Birmingham, if you like, on Teams for our first CRG of the West Midlands Perinatal Provider Collaborative. So it's very much on my in my thoughts today. I just like to say thank you to Mary for inviting me to come and have a chat with you about that. Yes, I'm an expert by experience, predominantly based at Birmingham and Solihull Mental Health Trust, but have done work also with the National Co-Production Group, worked with Mary in the past, which is a great experience. Thank you, Mary. And I'm a peer leader facilitator at NHS England too, and I do some work for the Royal College of Psychiatrists. And I'm very much keen on connecting and collaborating, and my passion is in perinatal. So hopefully I'll be able to share some insight with you. If Mary is able to share my slides, that would be great. Thank you.
Oh, Mary, sorry, Amy, are you not able to see them? I'm currently sharing them. I can try and reshare them again if you can't see them.
I can see them, yeah.
Oh, sorry.
Nobody else can see them. So, yeah. Okay, that's fine. Thank you very much. So, yes, you can go to the next slide, please, Mary. So first of all, very briefly, I just want to whiz through my story, and that's only really to remind people why we're here in the first place. So that's me 6.5 years ago, just having given birth to my second son, having had a fantastic birth. But as we know, it doesn't always continue in such a great way. Next slide. Thank you. So that is me during the time I was waiting for care. As you can see, not a very well lady at all. And then the good news is that the lady on the right is where I came after my treatment. Happily ever after. Yes, in some ways, but of course there's always places to go, and we're changed people once we've been through experiences like that, and we want to see where our life is going to go from there. So next slide, thank you. Oh, that's supposed to be pink. It looks green. Never mind. Okay, so I've recently been listening to a talk about leadership, and what struck me was this chap was talking about how pioneering leaders don't start with what are we doing and perhaps how we're going to do that, but actually go back to why. And why is always the core of what we're doing. And I was thinking, oh, I'm sure that's what I do all the time, is ask the why questions, and then ask myself again, why do I do that? Next slide, please. And I would say that experts by experience are, in a sense, experts at asking why. I think anybody who's been through a very challenging experience in life will ask those big questions, don't we? We sit there and we say, why me? Why is there so much suffering? Or even, why doesn't God answer? Why doesn't other people understand? Why doesn't this treatment work? And why didn't this happen in my care? And it's that why question. It's not just the children that ask that, it's us when we're going through difficult points. So next slide, please, Mary. Yes, here we have Martin Luther King. His why question. He didn't famously say, I have a plan, but he has a dream. And I think when we're in these collaboratives, this is what we want to keep at our heart, what our dream or our vision is. In other words, what is our why? And I would say if we can keep this wonderful image of the mother and child in our minds, that's going to help motivate us in what we're doing. This is a woman who is experiencing motherhood in all its fullness, and I think that is what we, at the bottom line, what we're all about. So next slide, thanks, Mary. So my whys for wanting to be involved is that in recovery, I and most experts by experience would probably tell you the same thing, that we're really keen to get well, consolidate and understand your own journey, where you've been through, and by able to share your experiences, that's part of that. Also really keen to help others through direct peer support. One of the first things that I wanted to do on being well was to get involved, knowing that it was a peer support worker who really gave me that bit of hope that I would actually get better, having not believed that it was possible. And then from there to think, well, what can we do from here, as well as helping women directly, but how can we get involved to improve healthcare for all through our insight? Next slide. So what's your why? Why are you here today? And hopefully it's because you've got that image of that woman living life to the full in your heart. But also there are details of that as why you might be here. And again, there's several things here which I'm sure you've all talked about this morning. I really apologise that I couldn't come and hear the other talks. But the bottom line is there, with all those things in mind, we want to improve patients' lives, and so we mustn't lose sight of that. That's our why. Next slide, please. So in terms of expert by experience work, EBE work, I'm just guessing the question, why would you want to do this? Why would you want to connect with service users? So there's many advantages, I would suggest, that as of course we're going to bring insight from our lived experience, not only of our health challenges, but also of using your services. But not only that, we'll bring a range of life and professional backgrounds and trainings and skills. So you know, I'm not just my diagnosis, and I'm just not my ex-diagnosis. I'm also a person with a past and a present, and things that I can bring. For example, I'm a professional musician by background, so I've been able to use those skills and therapeutic music sessions on the ward to as well as my lived experience. So there's the double benefit there. I found most EBEs are really motivated to learn and train and to get involved and be the best they can be to do this, and will bring you outside perspectives. And perhaps when people are, you know, facing burnout, and of course we know so much since the pandemic, people are struggling. Sometimes we can come in and give you that bit of boost, positivity, fresh hope. And also motivated to alleviate pressure from the workforce. Sometimes I'm the person who can say, oh, I'll do the post-meeting notes, or let me do that bit of admin for you. Relieve the pressure where you want to be getting involved and, you know, doing that clinical work and not doing all that admin. EBEs can connect you really well with communities of patients, particularly harder to reach people. We're out there in the communities. Other organisations, as I said in my brief intro, I work for lots of different organisations, and there's a lot of perspective and different resources and things out there that I can be sharing with you and others people too, because we're not just in a full-time job in the same organisation. And yeah, good resources and good practice, and there's so much reinventing of wheels. Let's try not to do that. Saves resources. Great. Next slide, please. Thank you. I'm going very fast today. Where are we? So yes, collaboration. We talked about connection. In order for service users to become service contributors, we need to create a really good environment for meaningful collaboration. So how are we going to do this? This is a big slide. It's very meaty, and this is something perhaps for people to take away more. I will make the slides available to you, but these are things that do deserve a lot more exploring. In order for us to use expert by experience input well, we need to work out how we're going to recruit people to do that. That'll be different in different places, and you might need to get advice on that. You may already have a great pool of EBEs at work, in which case that's fantastic. Representation, we need to make sure we've got people from different communities, and reimbursement. And I would say from experience as well that having good reimbursement policies is going to help with the representation, because otherwise you're just going to get retired people or very wealthy people who can afford to do this work without being reimbursed. And we want to make sure we reach the harder to reach communities and people in lower economic situations. Strategy. There needs to be a strategy for EBE work, that it's not just, oh, we'll have a few people in for a meeting and then hear what they've got to say and go home. There needs to be, clear direction as what's going. EBEs often, again, working for several different organisations or coming in, don't always have somebody who's a contact person. to supervise what they're doing, both for their sake and for the organisation's sake. So that's a really good thing to be exploring. Skill development we've got here, looking at good training so that we can be the best that we can be. And the psychology of this work is a huge, big subject, which maybe one day I'll do a PhD on, but it's a big thing. And we need to make sure that not only are people supported, but there's an understanding about psychological impact of the work. Communication, huge. It's the same across every sphere of life. We need to be communicated well with, back and forth. There needs to be clarity of what's going on and a consistency of approach. Mary has asked me to mention about the key considerations for funding EBEs, that there needs to be a commitment to this from the start, and a dedicated resource for lived experience work. And also clarity on whose responsibility that is, whether it's at the top from the collaborative or for individual trusts. But it must be facilitated so that we can actually do meaningful work, e.g. good preparation and follow up and communicating outside meetings so that things are properly enabled. Just coming to a meeting and going home, it doesn't really make a meaningful impact. I just wanted to mention that there are generally across the board a lot of inconsistencies with EBE policies. Either they don't have any, or that they different trusts work very differently, and NHS England again has its own different ways of doing that. So if we're going to be trust led in that way, there's going to be quite a lot of lack of equity for the EB involvement. So these are big discussions for you to be having with your collaboratives. At the Midlands, they are going to employ an EBE lead for overseeing all these kind of issues, and to make sure that is fully on the agenda, if you like. So again, these are the kind of things that can be talked about afterwards, if you'd like to follow any of this up. Right, next slide. Thank you. So service contributors can become service transformers if we're co-producing. And I was absolutely delighted when I read this mandate, if you like, from the West Midlands, which says that meaningful co-production must be at the heart of all the work by the Perinatal Provider Collaborative to design and deliver patient-centred care. And this EBE lead role will amplify the voices of those with lived experience, holding them at the centre of everything we do and bringing constructive challenge to other members of the board subgroups as required. I particularly like the word challenge there, and always wanting to bring a challenge. Thank you. Sorry, I've lost my slides here. Right. Apologies. Sorry, next slide, sorry. So I just wanted to remind people, hopefully something that you all do know about co-production and what it isn't and what it is. At the basic level, we know that involving patients can mean just looking at feedback forms, which has its uses, but we don't always know what happens to them, and it is in a sense tokenistic. Slightly better than that is consulting service users after you've made plans. Say, what do you think of this? That can have an input, but it's not really an opportunity to shape plans meaningfully. But what we do want to do is involve service users at the outset and every stage. And I was delighted again when reading the Midlands policy that in nearly every slide and page was the mention of embedding lived experience into all decisions. And this does transform things. Next slide. So what works well? I've got hundreds of examples of things that work well, but this is what I found does work well. I would say it's always going to be relationships before programmes, building relationships with service users and all that they can bring. There's a really good model we have in Birmingham with our ex-patients group, which is called the Friends of the MBU, and it truly is a friends group. So ex-patients, we come together, it's a recovery support group, if you like, but we've forged really deep, precious friendships in that, and encourage each other in confidence and study professional developments. There's some stories of wonderful transformations from, for example, one mum who came to the unit with no GCSEs, and just wondering what on earth she would do with her life after that. And the unit encouraged her to, you know, let's just try and get you your maths and English. And she did that. She's now done a first class degree in criminal psychology, and also a master's and passed with distinction, and is doing some fantastic work, all thanks to a lot of encouragement and peer support. And in that group that we do a huge range of different EBE work, from peer support on the ward, which I've said is crucial to women's recovery, to strategy, policy. So much good stuff going on there. Peer support work, absolutely important. I would say including people with the staff, team building days, access to staff communications as well. I found being able to access the trust comms has, you know, I've got more understanding of what's going on in the trust generally, other opportunities, connecting with people. Those connections and bringing people together is so important and exciting for collaboratives, especially. Training, good training for EBEs and for staff in how to work together, and that builds those bridges, makes us work together, and gets rid of any kind of us and them feelings. Yeah, I would say what another thing is really important, that with EBE work, that project involvement is not just kind of one-off meetings, but it's seeing things through from the beginning, the whole process and the end, and also communicating what outcomes we have, so that we're seeing what great transformative and impactful work that can be done. And it really can be this amazing statistics really about how more successful projects have been when things have been taken with EBs from the beginning to the end. I found that working in many different organisations like this, I've been able to really utilise those contacts and enable things to happen, such as research projects and things where staff have said, oh, we need people with this kind of experience, but we don't know where to find them. And I've said, oh, well, I happen to know somebody in this group or that group, and connecting those people. And that's been quite satisfying to see those things happen just through putting people together. Yeah, that the EBEs will have big networks, people that they've met in their travels through their health issues, and just generally communities, social media communities, other health organisations that they might be involved with, and real, grassroots organisations. Great to get those involved. Yeah, another thing that really does help and can be a huge problem when it's not is having good policies that do really facilitate this work with consistent principles. I've found that I can spend up to 50% of my time just filling in claim forms and working out all the different things like that. So yeah, that's something again mentioned earlier, but to really think that through carefully. Next slide. So as you say, it's a whistle-stop tour today, and there is a lot that could be cut up in. And if you do want to have any more explored area, it'd be probably good to get in touch with Mary, and who might be able to pass you on to me or anybody else who's a sort of experts in this area. So with all that in mind, hopefully this is not going to be true, but we'll all live happily ever after. It's a dream. We want that woman to be at the forefront of our mind. We all want to make a difference, and the best way to do that is together. I would say, let's connect, let's collaborate and co-produce with lived experience at the heart. Okay, thank you.
brilliant and right on the nail in terms of your timing as well. Well done.
Sorry.
It's quite unusual for me to be that that good with the timing. So brilliant. Thank you. And again, if anyone's got questions for Amy, please pop them in the chat and we'll make sure that they get answered. But lots of people thanking you for that, Amy, in the chat
Thanks.
already, so that's nice to see. So I'll hand back to Mary just to finish off, and I'll look forward to seeing you all for next month's webinar.
Thanks, Jenny. And Amy, yeah, thank you so much. I think you did an incredible job of covering so much, all relevant, all so important in such a short space of time. It was brilliant. Thank you. And it does bring us back to why we're doing what we're doing, which is essentially getting all the right people around the table and not just relying on goodwill and you know, engagement, which we sort of have done in perinatal, because I think we have done collaboration well, but actually bringing those people around the table and putting a formal governance structure around that to enable us to make things better for women and families. So yeah, Amy, thank you. I don't know if it's helpful right at the end just to kind of, I suppose, give a current status on where we are with perinatal provider collaboratives across the country. So as it stands, all regions are on track to stand up perinatal provider collaboratives by October 2023, so October this year. You know, as Andrew said, there are areas that are really far ahead in their thinking on this, and there are actually still a couple of areas thinking they may go live in April, but certainly across the country we'd look for October 2023. Roughly at the minute, regions and systems are thinking we would have around 12 perinatal provider collaboratives that would cover the whole population. This could change, I will caveat that, because at the minute we're at a really important bit around due diligence. So nationally, we've released a selection criteria. So this is a criteria that our lead providers, so those providers that are going to be the lead within the collaborative with their ICB partners and their other trusts, the lead will have to meet a criteria, as you would expect. So that's gone out. We've also released the funding envelope. So no money has transferred, but it's essentially, here's some data. This is what your funding would look like for the MBU element, so not community element, for standing up your PC. What does this look like? So at the minute, there's a big bump that systems have, and that's to be worked through with clinicians, with people like Amy and lived experience, to be like, okay, what's the reality? Does this data reflect what's happening now in terms of patient flow and experience? Who are we talking to get more of an idea around that? So all of that work is going on, and that will inform the provider collaborative. So whilst we think we might have 12 and those footprints make sense, maybe through this work that might change. But that's where we're up to as it stands. So I will pop on, I realised I didn't put a resource slide at the back of this pack, which we will be sharing all the slides, but that will link to our Futures platform for perinatal provider collaboratives, and that has the national guidance, that has a real big set of FAQs, it has the selection criteria that I've spoke to, so I'll add that on, but obviously my details and Jenny's and others will be on there as well, so further questions, do send them through. Thanks. Is that us done, Jenny?
I think it
2
is.
minutes
Thanks
over.
everyone for joining. Brilliant. Okay. See you next
Thanks,
time.
everyone.